is something that is not a new concept, I would say. Historically, there has been a high percentage of patients with CML in chronic phase undergoing allogeneic stem cell transplant who has remained treatment free following transplant. And we do understand that that has been way back in 2007 and then again demonstrated in 2010. And especially those patients who during the interferon era who underwent transplant, and those patients who were transplanted while in the era of the TKIs also had very good durable responses. So again, we have this concept of the operational cure that has come into the picture of CML, and TFR achieved without transplant in a subset of patients receiving interferon alpha was a very well documented fact. And patients with sustained undetectable BCR-ABL at 2 years on interferon alpha remain disease-free at a median follow-up of 8 years. But this happened in about 20% of the patients, and this was published in this paper by Hagop Kantarjian, who probably the MD Anderson has got the maximum experience of using interferon, and they clearly demonstrated that this was possible in CML. So what did transplant interferon data suggest to us? And it suggested a few points: that it is important to achieve a deep molecular responses, which is what was seen in a common factor in whether the patient underwent transplant or whether the patient received interferon. And it is important to also sustain those responses over a period of time. We also realized that there were patients who were in the early phases and the early phases of the disease who had a better chance of attaining those responses. And this was particularly true for those patients who went on to undergo transplant in the early phase of the disease. And lastly, the sustained deep molecular responses could translate into operational cure, and this was something that was seen with the interferon data. So what are the thoughts on TFR in the era of TKI? So we do understand that tyrosine kinase inhibitors induce rapid induction of complete cytogenetic responses, the highest proportion that one came across till the TKIs came into the picture, and the second generation also came into the picture. A higher proportion of patients going into deeper molecular responses were also noted, and there was also clearly that the ongoing deepening responses were sustained when you were compliant with the treatment, and it was a matter of time dependent. It was time dependent that the longer you had exposure to a tyrosine kinase inhibitor, and the better was your chance to sustain those responses. But of course, we do understand that over a long term, as my previous speakers have spoken to, and Dr. Chitalkar spoke, the adverse events that have been associated with TKIs is not something that can be neglected. And lastly, the economic toxicity that comes through with the prolonged use of TKI, and also something which we always consider, which is impairment in quality of life in many of these patients. We tend to ignore this aspect in the light of the fantastic responses in terms of control of the disease. But when we actually look at the quality of life, there is definitely an impairment. So the question is, can all patients actually adopt the strategy of treatment-free remission? And if not, who are the ones who can be advised to adopt the strategy? So we do understand from the various studies, including the IRIS study, that there were people who were achieving molecular responses over a period of time. And we know that both from the INEST-ND study and the Decision study, and also the CML4 study, where from the German group, where they use higher doses of imatinib. The stronger the TKI and higher the dose of imatinib, better the chances of achieving MR 4.5 over a time period. And the IRIS study clearly demonstrated that these responses tend to continue to occur even beyond the time point of 5 years. So therefore, the question that emerges is, can we persevere with imatinib itself with the objective of treatment-free remission? And is the second generation TKI going to do a better job in achieving this objective? And are there prognostic factors to start with which can tell us who is going to achieve that response. So the first time 10 years ago, which was published, was the STIM study, which looked at imatinib in patients who had sustained responses and achieved undetectable BCR radial transcripts. And in those patients, and in the long-term follow-up, what came about was that the probability of relapse-free survival was about 43% at 6 months, and it dropped down to about 38% at the end of 24 months. And the probability of treatment-free survival at 6 months was about 59%, and at 24 months, about 41%. But this was a very, very defined population who consistently had an undetectable BCR-ABL transcript over at least 3-year period. The STEAM study also demonstrated that those patients with a high SOCAL score did worse than those patients with a low SOCAL risk score. And so thereby saying that this particularly the low SOCAL risk score group were the people who needed to be targeted mainly for TFR. The TWISTER study looked into the objective of the study was to demonstrate sustained treatment-free remission in CML, stopping imatinib therapy after stable, undetectable, minimal residual disease. And there was opportunity to reintroduce imatinib also at the time of molecular relapse. So quantitative PCR every month in a year 1, every 2 months in the first 2 years, and every three months in the year 3 was considered. So all patients who had achieved undetectable MRD greater than 24 months were included in the study. Much like the STIM study, this also demonstrated close to a 42.7% TFR at the end of 1 year. So all patients who relapsed, importantly, all patients were sensitive to imatinib after treatment, and 8 patients who lost MMR regained responses after a median duration of treatment of 2 months. So one of the largest studies which looked into this was a EuroSKI study, which included almost 756 patients. And what, in a nutshell, what the EuroSKI study showed was 61% were free of were in MR at 6 months, and 55% were free of disease at 12 months. So in patients receiving imatinib, longer duration of imatinib therapy contributed to better chances of achieving the goal of TFR, deeper responses, and the minimum of sustaining a molecular response of MR4 duration was also important. And there were some patients who were on interferon in this group, and longer duration of pretreatment with interferon also contributed to better outcome in these patients. Since then, there have been several studies, which is a series of studies which included the first generation, the second generation medications, mainly include dasatinib and nilotinib. And these are a series just for us to understand. There was a whole load of studies which came about. But what do we conclude from these 3 main studies as far as TFR is concerned is achieving deeper molecular response is critical, sustaining that response for sufficient duration is critical, longer duration of TKI intake will favor a better outcome. There was some conflict data as far as SOCAL risk score is concerned, but one can hope for a TFR if selection criteria adhere to the tune of about 40 to 50% across the board. So this was, can second generation improve the outcomes? This was the STOP second generation TKI study. 24 patients lost MMR after a median follow-up of 4 months. The treatment-free survival probability without losing the major molecular response was about 61%. And all but 1 patient who lost MMR achieved regained their responses on reinitiation of therapy. So again, approximately about 41.7% versus 67%. Prior history of suboptimal response was a contributing factor to not achieving a TFR. So that comes us to what are the predictive factors for maintaining TFR. So if you look at some of the major studies, the STIM study demonstrated that low risk SOCAL and a high natural killer cell count contributed to better chances of achieving TFR. The TWISTER study demonstrated a deeper unrecordable MRD of less than 9 months, duration of interferon treatment greater than 12 months, and achievement of unrecordable MRD of less than 9 months contributed to better outcomes. The KIDS study, which looked at dasatinib, looked at the digital PCR, which is a more sensitive tool at screening. And if your digital PCR values were less than 0.468, they had a better chance of achieving a TFR. The Euroski study again showed the importance of natural killer cell activity in contributing to TFR. And the DARDI study, that is dasatinib discontinuation study, demonstrated that any history of imatinib resistance in the past contributed to lesser chance of TFR. And again, as the Euroski and the STIM study, natural killer cell count contributed to better outcome, higher natural killer cell count. So this is just a summary, a table, which is a busy slide. I will not go through this too much, but just got to say that whatever I highlighted in the previous slide were some of the things that emerged in terms of determining who are the patients who will go on to have a sustained TFR. So so whom do we recommend for going in for TFR? So these are the European guidelines and the NCCN guidelines. And I sort of, in terms of its simplicity, I like Tim Hughes and the Adelaide guidelines, which clearly says that we need to have an institutional criteria for this in terms of who we have to choose. We should have a stringent molecular testing which can be reproducible. SOCAL risk score, which is low, is a better chance. All those are in green are the people who can go in for a TFR. The BCR-ABL transcript, there is some documentation that the E14A2 have a better chance. The type of CML in chronic phase is important. You need to look at the duration of TKI therapy, the depth of molecular response, and the duration of that depth of molecular response. Also, the longer you have had a deeper response, the better chances of achieving that kind of a remission. So, in a nutshell, as far as who's going to benefit, we should look at the availability of high quality, internationally standard, accurate, sensitive RQ-PCR laboratory, rapid turnover time of the RQ-PCR test within 4 weeks, capacity to provide an RQ-PCR test every 4 to 6 weeks when required, and structured follow-up established to enable a rapid intervention if BCR-ABL is rising. So I will conclude that discontinuation of TKI in CML patients with sustained DMR is feasible and safe. On an average, 40 to 60% of the patient would still relapse after achieving a TFR, and molecular relapses typically occur within 6 months. Those relapses are lesser in the next 6 months, and the chances of having a relapse if after 12 months of cessation therapy is exponentially lower. So most patients who regain responses when TKI treatment is reinitiated is consistently has been reproduced. And although late relapses are rare, they do occur, and which means that continuous monitoring in these patients is mandatory. So attempting a second generation, second TKI discontinuation after molecular recurrence is also still possible. But again, you need to go through those time frames of at least sustaining the deep responses for 2 to 3 years. And we can expect, even in these patients, about 30% of them to actually go into a state of TFR. So with that, I will conclude my talk, and it's back to you, sir.